Welcome to MedSimu Nursing Podcast. Today we're doing a deep dive into a really crucial topic, especially if you're prepping for the NCLEX, fluid volume deficit. Dehydration. It sounds basic, maybe, but the details are so important for patient care. We're joined by an expert who can really unpack this for us. Welcome.
Glad to be here. It's definitely fundamental. Understanding fluid volume deficit well is just non-negotiable for safe nursing.
Absolutely.
So at its heart, dehydration is simply when the body's fluid output is more than its intake. Pretty straightforward concept there. But the treatment goals, they're threefold, really. Restore the fluid volume, replace any lost electrolytes, and, crucially, fix whatever caused the deficit to begin with.
Okay, so it's definitely more complex than just telling someone to drink water.
Oh, absolutely.
Now, the background information we looked at breaks dehydration down, different type, right?
That's correct. We typically talk about three main categories, isotonic, hypertonic, and hypertonic dehydration. And each one has its own specific characteristics, different implications for the patient.
Let's start with isotonic then. What's the main takeaway for that one?
Okay, so isotonic dehydration. This is where the body loses both water and electrolytes, sodium, chloride, things like that, in pretty much equal proportions.
Okay, equal loss.
Exactly. And it's actually the most common type you'll encounter. You'll often hear it called hypovolemia.
Hypovolemia, right.
The big problem here is the decrease in circulating blood volume. Less volume means less effective perfusion, less oxygen getting to the tissues.
And that impacts everything.
It really does. And something really important, especially thinking about exams like the NCLEX hypovolemia, can get serious fast, particularly in patients who already have heart issues. You might see subtle vital sign changes even before their blood pressure tanks. Those are key early warnings.
That's a critical point. Speed matters. So what causes this isotonic type? What are the triggers?
Well, several things. It could just be inadequate intake, not drinking enough, and not getting enough electrolytes.
Makes sense.
Or you could have fluid shifts where fluid moves out of the blood vessels into other spaces. And then there are excessive losses of fluids that are isotonic themselves, like think significant bleeding or prolonged vomiting or diarrhea.
Okay, got it. Bleeding, vomiting, diarrhea, classic causes. So that's isotonic. How is hypertonic dehydration different?
Right, hypertonic. Here, the key difference is that the body loses more water than it loses electrolytes.
More water loss. Okay.
So this imbalance changes the concentration of solutes, like sodium, in the blood plasma. It gets more concentrated.
Right.
And because the environment outside the cells is now more concentrated than inside, water gets pulled out of the cells. Osmosis, basically.
So the cells actually shrink.
Exactly. The fluid shifts from the intracellular space to the extracellular space, causing cellular dehydration. The cells themselves are losing water.
Wow, okay. That sounds potentially quite damaging at a cellular level. What kind of situations lead to that?
Yeah, it can be serious. You see it in conditions where there's significant water loss without matching electrolyte loss. Think excessive sweating, like with a really high prolonged fever.
Okay.
Or patients who are hyperventilating, blowing off a lot of water vapor. Diabetic ketoacidosis is another one.
Okay, right.
Also, severe watery diarrhea, some types of kidney problems like early renal failure, and a condition called diabetes insipidus, where the kidneys can't conserve water properly.
So a different set of causes driving that water loss.
Precisely.
Okay, that clarifies hypertonic. What about the third type, hypotonic dehydration? How does that contrast?
So hypotonic is pretty much the flip side of hypertonic.
Yeah.
In this case, the body loses more electrolytes than it loses water.
More electrolytes lost this time.
Correct. And again, the problems come from fluid shifts, but the direction is different. Here, the plasma becomes less concentrated than the inside of the cells.
So the fluid moves into the cells.
Exactly. Fluid moves from the plasma and the interstitial space into the cells. This leads to a decrease in the circulating plasma volume, but also causes the cells to swell up.
Self-swelling, okay.
Yeah.
And what situations typically cause hypotonic dehydration?
You often see this in patients, maybe with chronic illnesses. It can also happen, interestingly, if someone loses fluids and then replaces them only with fluids that are very low in electrolytes, like drinking huge amounts of plain water after sweating a lot.
Replacing loss with the wrong kind of fluid.
Yes, exactly. Or excessive IV administration of hypertonic solutions. Other causes can include things like renal failure, especially later stages, and chronic malnutrition.
Okay, this breakdown is super helpful. Isotonic, hypertonic, hypotonic, different loss of different shifts. So as nurses on the floor or preparing for that NCLEX question, How do we spot fluid volume deficit? What are the key assessment findings?
Assessment is absolutely paramount, and you need to look across multiple systems.
Right.
Let's start cardiovascular. You might feel a pulse that's rapid but weak and thready.
Okay. Fast but weak pulse.
Yes. Blood pressure will likely be low, and you'll often see orthostatic hypotension, that dizziness or drop in BP when they change position, like sitting to standing.
Orthostatics, check.
You might notice their neck veins or the veins on the back of their hands like flat, collapsed. Peripheral pulses radial, pedal might feel diminished, hard to find. And if they have a central line, you'd see a decreased CVP, central venous pressure. Even dysrhythmias can occur.
Okay. Quite a few cardiac clues. What about breathing? Respiratory signs.
You might see an increased respiratory rate and depth. The body's trying to compensate,
Makes sense. Neuromuscular changes.
Yeah, this is important too. You could see decreased CNS activity. That might range from just lethargy, seeming really tired,
Sluggishness.
right, all the way to confusion, or in severe cases, even coma. Fever can sometimes be present too, paradoxically, and patients might complain of muscle weakness.
Okay. And the kidneys? They must show signs.
Absolutely. A classic sign is decreased urine output, oliguria. If the kidneys aren't getting perfused well, they just can't make much urine.
Low output. Got it.
Yeah,
What about skin? That seems like a common check.
definitely. You'll likely see dry skin. And that classic sign of poor skin turgor, you pinch the skin, maybe on the forearm or sternum, and it stays tented up instead of snapping right back.
That's right.
Dry mouth, dry mucous membranes are also common.
And GI system. Any clues there?
Yes, things tend to slow down. You might hear decreased or absent bowel sounds. Constipation can be an issue. The patient will almost certainly report feeling thirsty. And look out for recent unexplained weight loss. That can be a big indicator of fluid loss.
Thirst and weight loss. Okay. Lastly, labs. What blood or urine tests help confirm it?
Several labs can point towards dehydration. Serum osmolality might be increased. The blood is more concentrated. Hematocrit might be high, again, because the blood cells are concentrated in less plasma volume. BUN, blood urea nitrogen, often goes up. Serum sodium can be high, low, or normal, depending on the type of dehydration, which is why understanding those types is key.
Right. Connects back to the types.
Exactly. And urine-specific gravity will usually be elevated. The urine is more concentrated because the kidneys are trying desperately to hold on to water.
Okay. That's a really comprehensive assessment picture. Extremely helpful.
Mm-hmm.
So we've identified the problem using these signs. What are the core nursing interventions? What do we do?
Well, the main goals are, 1, keep monitoring everything closely. 2, stop any further fluid loss if possible. And 3, replace the lost fluid safely.
Monitor, prevent loss, replace fluid.
Precisely. So ongoing assessment is key. Keep checking those cardiovascular signs, respiratory status, neurochecks, INO, skin checks, GI status. Watch the trends.
Constant vigilance.
Absolutely. Then, for replacement, if the patient can drink, oral rehydration is usually the first choice. Small sips, frequently. Oral rehydration solutions often contain electrolytes too, which is ideal.
Oral first, if possible.
Yes, but if they can't drink or the deficit is severe, then IV fluids are necessary.
IV therapy.
And with IVs or even with oral intake, strict monitoring of intake and output is just critical. You need to know exactly what's going in and what's coming out to guide the therapy and avoid overload.
Makes sense. Does the type of IV fluid matter based on the type of dehydration?
Yes, very much so. It's not one size fits all. For isotonic dehydration, you generally give isotonic fluids, like normal saline, 0.9% sodium chloride, or lactated ringers. They match the body's normal concentration.
Okay, isotonic for isotonic.
Right. For hypertonic dehydration, where the cells are shrunk, you need to give a hypotonic solution, like half normal saline, 0.45% sodium chloride. This helps gently rehydrate the cells.
Hypotonic fluids for hypertonic dehydration.
Correct. And for hypotonic dehydration, where the cells are swollen and plasma volume is low, you might need a hypertonic solution, like 3% saline. This helps pull fluid back into the vascular space.
Okay.
But hypertonic solutions have to be given really carefully, usually in an ICU setting, with close monitoring, because they can cause rapid fluid shifts or fluid overload.
High risk. Needs close watch.
Yeah.
Got it. Are there other treatments involved besides fluids? Medications?
Often, yes. You need to treat the underlying cause, right? So if it's diarrhea, maybe antidiarrheals. If it's vomiting, and emetics,
Treat the cause?
infection,
Yeah.
antimicrobials,
Right.
fever, antipyretics. If their oxygen saturation is low because of poor perfusion, they might need supplemental oxygen.
Okay.
And you absolutely have to monitor electrolytes closely, sodium, potassium, etc., and be ready to replace those or correct imbalances as ordered.
Right. Electrolyte management is key too.
Crucial part of it.
This has been incredibly clear. Thank you. Let me try and do a quick recap, especially for everyone listening who's got the NCLEX in their sights. So we talked about fluid volume deficit, dehydration. Remember, there are three main types based on what's lost relative to water. Isotonic, equal loss. Hypertonic, more water loss, cells shrink. And hypotonic, more electrolyte loss, cells swell. Knowing the assessment findings is vital. Think thready pulse, low BP, orthostatics, poor turgor, low urine output, altered mental status, and specific lab changes like osmolality, hematocrit, BUN, specific gravity.
It's a good summary.
And interventions focus on monitoring closely, stopping the loss, and replacing fluids orally if possible, or IV fluids matched to the type of dehydration. Isotonic for isotonic, hypertonic for hypertonic, hypertonic for hypotonic, carefully. Plus, treating the cause and managing electrolytes.
Exactly.
Understanding this whole picture isn't just exam prep, it's fundamental to keeping patients safe.
Couldn't agree more. It's core nursing knowledge.
Well, thank you so much for breaking all of that down for us today. Really appreciate your expertise and insights.
My pleasure. Happy to help clarify it.
And for all of you listening, we hope this deep dive has solidified your understanding of fluid volume deficit. Join us next time as we tackle another essential nursing concept right here on MedSimu Nursing Podcast. Thanks for tuning in.